Assalamu alaikum wa rahmatullah. I'm Dr. Ali Taib, orthopedic surgeon, associate professor of orthopedics in the University of Khartoum. Welcome to our channel Ortho Clinic. We're going to talk about glenohumeral dislocation, anterior shoulder dislocation, common injury in the shoulder. It constitutes about 98% of shoulder dislocations. Starting with the anatomy of the shoulder joint is an articulation between the glenoid fossa and the head of the humerus. The glenoid fossa relatively is very small compared to the head of the humerus. This is why this joint is very unstable. The joint is also covered by the capsule of the joint and the glenohumeral ligaments, which are thickening of this capsule. Then comes the glenoid labrum, which is attached to the rim of the glenoid fossa. It adds depth to this fossa. Also, there are muscles around the joint which add to the stability of the joint. They are dynamic stabilizers of the joint. These muscles are the rotator cuff muscles covering the joint, also the deltoid muscle, the pectoralis major, and the latissimus dorsi muscles. Long head of the biceps muscle also runs over the capsule and is adding additional stability to the joint. There are factors which predispose this joint to dislocation. First of all, the shallowness of the glenoid post socket in relation to the head of the humerus. It is relatively shallow, and this makes the joint unstable. Other factor is the extraordinary range of motion in the joint predisposes to dislocation also. There are other factors like laxity of the joints and the dysplasia of the glenoid fossa sometimes add to the instability of this joint. Mechanism of injury. Usually the anterior shoulder dislocation occurs after a fall on the outstretched hand. Other mechanisms like blow from the back of the shoulder might cause dislocation. In this anterior dislocation, the head of the humerus is driven anteriorly or forward, and it tears the capsule and avulses the glenoid labrum. This is called Bankart lesion. Another lesion might occur, which is the indentation of the posterolateral part of the head of the humerus. This is called Hill-Sachs lesion. Clinical features of anterior shoulder dislocation. If you compare the two shoulders, on the affected side, there is flattening of the shoulder contour. There is bulge infraclavicularly, and the joint is very painful, and the patient is unwilling to move or to be examined. If you feel the joint, there is a bulge in the infraclavicular fossa, which is the head of the humerus. It is always important to examine the nerve, which is usually the axillary nerve is affected in anterior dislocation of the shoulder, and also to feel the pulse for integrity of the axillary artery. Imaging. X-ray, usually anterior-posterior views of the shoulder show the dislocation, show the head of the humerus is outside the glenoid socket, and it might also show associated fractures of the greater tuberosity or the neck of the humerus or head of the humerus. A lateral view or an axillary view will differentiate between anterior and posterior dislocation of the shoulder. Sometimes we do CT scans if there is any subtle fractures or injuries might show on the CT scan. The MRI is sometimes also used to show mainly the soft tissue injuries, and like the capsule tears and the labrum or the avulsion of the superior part of the joint where the long head of the biceps is attached. Slab lesion. Treatment of this dislocation, anterior dislocation of the shoulder. Usually reduction is done under sedation or general anesthesia. There are three main types of maneuvers which can be used to reduce the shoulder dislocation. Stimpson's technique, which is a simple technique. The patient is lying prone and there is some weight attached to his arm, and the dislocation reduces gradually. This is very simple. The other method is Hippocratic or modified Hippocratic method, where the surgeon and an assistant who is applying counter traction to the arm, the surgeon will apply traction and the assistant will apply counter traction and pushes the head of the humerus in place. This is a safe method. And the third method is Kocher maneuver. Kocher maneuver sometimes might cause fractures in elderly patients. Be careful about osteoporotic bones in elderly people. After the shoulder is reduced, a check X-ray should be taken to make sure that there is reduction of the dislocation and to see if there is any fractures that, like the greater tuberosity, might get reduced or might need to be reduced operatively. The arm is put in a sling for 3 weeks. Also, but after 2 weeks, you see the patient, passive movements might be commenced. These are like pendulum exercises and steering movements. After 3 weeks, active exercise of the shoulder should be undertaken to improve mobility of the joint and muscle strength. Also, with this dislocation might get rotator cuff tears, which also show on the MRI, and nerve and vascular function is checked. Also, serious fractures associated with the dislocation like the head of the humerus or the neck of the humerus, these need operative treatment. Late complications associated with this fracture is shoulder stiffness, unreduced dislocation, recurrent dislocation, and subluxation. Shoulder stiffness should be prevented by early exercising of the shoulder, passive and active exercise of the shoulder to prevent stiffness of the shoulder. Sometimes after prolonged physiotherapy, you might need to manipulate the shoulder to improve the range of motion. This is important to avoid fractures in this maneuver because the bones are osteoporotic, especially in elderly people. Unreduced dislocations, unfortunately, we in Sudan still see some neglected unreduced dislocations. If the patient comes 2 weeks after dislocation, close reduction might be tried if succeeds. If it doesn't succeed, might need to do open reduction. After 2 or 3 weeks, soft tissues will heal and the bone become more osteoporotic, and manipulative reduction should be avoided. The best is to do surgery here and warn the patient about the results might be also compromised, not as expected.